Today, I'm going to interview someone very special about a topic that's incredibly common. So it's actually Professor Spierings, not me. I'm Dr. Spierings, but my dad is Professor Spierings, and he's sitting here with me today for this podcast about, well, of all topics, headaches, because this is the book that you just published. And this is kind of the equivalent of Skintelligent, but for headache.
That's correct. Yes, that's correct.
Because I think you got your idea from my book.
Of course, not the topic.
Not the topic.
No, not the topic, but to write a book for the patient or the lay audience in a broader sense that I copied from you.
Copied from me, of course.
Yes,
copied from me.
That from you.
So this is the book. It's available on Amazon, right? Yes.
Amazon, Barnes and Nobles
in the United States. And it's coming out in couple different languages, and the audiobook is coming as well.
The audiobook is already available.
The audiobook is available. So the book is about headaches. So now I like to deal in a subject, dermatology, that is super common. So everyone has skin, and almost everyone has a skin disease at some point in their lives. So my dad works in the field of neurology, which is not quite like dermatology, but almost everyone in the world will have had a headache at one point in their lives.
Yes, headache is such a common experience. I always like to say that people who deny never to have headaches probably have another neurological problem. That's bad memory.
Or they're lying. So one or the other.
Or they're lying, that's true too. But if you look at it from a neurological perspective, it would be bad memory.
Yeah, and it's always interesting because like the most common things that afflict humans, like the common cold, headache, in my field, like dry skin, are seemingly the most difficult to treat or have like people perceive it as having no treatment.
Yeah, and that's certainly also the case with headaches. And that's one of the reasons I, in fact, wrote my book, because I think that we have made a lot of progress developing treatments over the last 3-4 decades. We have very good medications available for the treatment of headache, in particular migraine. And a lot of people don't know about it. They still walk around with headaches as if there's nothing you can do about it. Yeah. But there is a lot of things progress that has been made.
Yeah, and the same is in dermatology. Like people think there's no treatment for acne that's very good. There's no treatment for melasma that's any good. And it's always like, no, these are super common problems. There's no treatment for eczema, but we have excellent treatments. But it's about the patients or the people who are suffering from them don't realize that they're available. So that's partially why I wrote my book as well.
Exactly, because there's a lot of misunderstanding.
There's a lot of misunderstanding.
Also about the significance of, let's say, acne as a medical problem as opposed to a social or psychosocial or cosmetic problem. And the same with headaches. People just think that they have to suffer, that there's nothing
It's a part of life.
It's a part of life, which to a certain extent it is, but certainly not to the full extent.
No.
And especially when you have intense headaches, in all likelihood you have migraine. We have very good, as I mentioned already, treatments available for that. And also if you have frequent headaches, even if they're not terribly intense headaches, certainly if you have frequent headaches, that also should be looked at because there also may be a medical cause.
It's totally like debilitating. And the stats are pretty interesting actually, because like obviously the statistics are in the book. Half of the population has a headache at least once per month. That's a lot of people.
Yeah, that is. But headache is a very common symptom.
Yeah, it's super common.
15%
once per week, and that's still 15% of the population of the world.
That's 1 out of 7 people has a headache at least once a week.
And then 5% have daily headaches. Again, 5% of the population of the world is a massive amount of people to be suffering from the same-ish problem. Not quite the same because there's lots of headaches. We'll talk about that in a second, but on a daily basis. So that's pretty terrible. So that's the context of what we're talking about. So almost anyone who's watching this is going to have had a headache.
Yes.
I mean, we can pretty much say everyone who's watching this has had a headache. I certainly have. You sort of maybe have had 1 or 2, though your memory might be lacking.
Everybody has headaches every so often. Fortunately, I'm not a headache sufferer myself, so I don't have migraine. But I think headache in a certain way is part of life. I myself think that headache is very strongly tied into fatigue. And
we'll get to that.
And we'll get to that, so I'm not going to jump the queue.
Don't jump the gun, because that was the next thing. So
okay, that's fine.
When I read this book, like a lot of this I know because like I've been around this for 44 years, which is my entire life. So a lot of these ideas and concepts I know, but then reading them in like an organized manner kind of was like reading a medical school textbook, like a reminder textbook, like, oh yes, this is that. Because you go into a lot of like medical stuff as well around headaches. So it was kind of a refresher about all those general medical things that I don't normally talk about or think about. But I think the one thing I got from reading the book, because it was reiterated over and over again, is that like basically fatigue is the root of all evil.
That's what I think.
It comes across pretty damn strong in this book.
And that's also the way I wanted to come across, because I don't think that's generally realized. I think people tend to relate headache to stress.
Yeah.
And maybe that's the most obvious thing. When you're stressed out, you end up with a headache. Although, for example, migraine is a typically post-stress relaxation headache.
thing.
But I don't think that stress is really the main issue when it comes to headaches. I truly believe that fatigue is that crucial issue, that if you feel tired and you deny that for yourself or you don't pay attention to that, I think headache is the next symptom that will try to slow you down and try to make you pay attention to your body.
Stop.
Your body. Yeah. And unfortunately, if you do happen to have migraine, which is a genetically determined and inherited condition, you end up with a very bad headache. And that's really not, I think, the purpose of nature.
It's to get you to slow down.
People such bad, debilitating headaches, because that makes the situation even worse.
So I think people, like generally with my patients as well, and me as well, like we don't like to admit we're tired.
Exactly, but fatigue is very important. And again, a lot of people think it's when they feel tired, they think they feel stressed out.
Yeah.
When you feel tired a lot or chronically, and you go and see a healthcare provider, for example, a healthcare practitioner, they think you're depressed, that you feel tired all the time because you're depressed. And I'm sure chronic fatigue can be a symptom of depression, but that would be the last thing I would think about, or I would want healthcare practitioners to think about, because I think fatigue is a physical symptom as much as headache or any other complaint is, and it should be taken seriously and also addressed as such.
Like I know if I don't sleep well and I have to work the next day, and I know I have a really long day at work, I get really stressed out thinking I'm going to be tired and I'm not going to be able to do my job properly. Like,
and of course that's true, because when you're tired, you cannot concentrate very well either.
You end up eating dodgy food or whatever. So there's a whole bunch of issues there. But so what I found, so it's a lack, but how you define fatigue is when you have a lack of metabolic energy to do things that you need to do. And I think the page 128 of this book, just FYI, page 128, so you come from like a lineage of headache experts. So
I do. Yeah.
And that's explained in the book. So like basically there's Dr. Wolf back in the 1950s.
The first half of the last century.
And he was like the original researcher into headache and the causality of headache or the underlying pathology.
Yes, the underlying mechanisms and causes,
which causes pain in the head. And then his like kind of protege was Dr. Graham,
right?
Who I met when I was very young, and that's who got you to move us to the United States. Thanks, Dr. Graham. He's unfortunately not with us anymore, but if he was, I'd have a word.
Okay.
So Dr. Graham is why we moved to the United States, and then you are the third in the line of kind of the original researchers into headache. So that's been about like what, you're how old now?
I'm 72 now.
72, so that's about 50 years.
Yes, because I met Dr. Graham back in 1974. In fact, in May of 74. So that's 51 years.
51 years
ago.
So 51 years and seeing patients. So 51 years of clinical experience, basically.
Yeah, of course. When I met him, I was still a medical student.
Oh, right.
So, maybe you could call it even a pre-med
But you finished medical school when you were 23.
I finished medical school in 1971. So I was 28.
Oh, right. Okay, fine. But that was also
27, because it was in January of 78. And
were the Beatles still around then?
So the Beatles were done already.
Oh, or they were done already.
The Beatles was in the first half of the 1960s. So that's when I was an early teenager.
Teenager.
Yeah, in the early 60s.
Okay.
So I've been involved in headaches for more than 50 years, since 1974 when I met Dr. Graham. And he was the one who got me into headache. I didn't really have that interest. I had an interest in neurology, but not necessarily in headache or migraine. But he was the one who kind of
sucked you in.
Yeah, or dragged me into that.
Dragged you.
So,
there's no one really currently who has as much experience clinically with headache than you, technically.
I would definitely
currently alive.
say that. I would definitely say that also because, as you said yourself, I have come from a very strong headache lineage.
Yeah.
Professor Wolf was really the first one, I think, to look at headache in a scientific manner.
Yeah.
And he also did that in a very, very systematic way. He was in New York at New York Hospital and Cornell Medical Center. And he basically studied headache in all its presentations and causes. And so I think he laid the foundation. He published a thick book.
Yeah, I've seen it.
Headache and other head pain. You have seen it at home as well. And in fact, Dr. Graham was his first assistant back in the 1930s. And I was Dr. Graham's last fellow in the early 80s because Dr. Graham passed away in 1990.
Yes. So I was 9 years old when he passed away, and I remember that time.
Right.
And that's all explained here. It's not super in detail, but you do describe a bit about what Professor Wolf did with his original research. But what I want to draw our attention to is page 127 and 128, where you talk about your mentor, Dr. Graham, and he published a book in 1955 called The Treatment of Migraine. And he talked about errors in living. Now, this is this is 1955. So errors in living. And I found this so interesting. He wrote that one of the errors in living for the migraine patient is sleeping late on Saturdays, Sundays, and holidays. The patient with migraine needs a good deal of sleep, but not in the morning.
Right, not oversleeping.
So not oversleeping.
Morning, no, because oversleeping is also certainly a trigger. And that may be a more specific trigger for migraine. As I said, migraine is more of a relaxation than a stress headache.
Yeah, and he also wrote errors in living, failure to take proper vacations. And this is for migraine people, not generally. But I guess you can relate
I think
this
it may be for everybody.
General humans. So,
yes.
Again, error in living, failure to get away from their children periodically.
Maybe that includes the dog too.
That's maybe, the dog as well. Errors in living. So, lack of exercise, lack of recreation, aiming for impossible goals, and worrying when they cannot be attained.
These are very general things.
They're pretty general.
And this is, in 1955 he published. It's a little booklet. It's really an interesting read.
Yeah, it seems like it.
Yeah, he published it for the patient as well, and he was very strong. Dr. Gray was an internist, so Professor Wolf was a neurologist. I'm a neurologist. Dr. Graham, who's kind of in between us, he's an internist, but he had a very strong interest in psychiatry. Now, you also have to remember that back then, when he practiced headache medicine or headache management, that we didn't have a lot of medications available to us. So he was really trying to help people by helping them organize their lives and making sure that you can also see coming through all of what he wrote down there as errors in living, that he was very much focused on making sure people didn't get excessively tired as well. I didn't really invent that. It's based on his teaching. But also I certainly looked at that in my own patients and kind of developed on it based on, the thousands of patients that I have seen over the last 4 or 5 decades. And Dr. Graham really was a strong believer that headache is a chronic ailment and these patients need to be followed long term. He did that, and I've done that myself. I've seen patients for decades, for example, and carried them through a good part of their lives.
So I think what in modern I hate that modern medicine, but of course the concepts of like functional medicine has become a big deal. I don't know how much you know about functional medicine, but anyway, the functional medicine is the idea that in traditional medicine, we don't look at like the patient holistically or look at their lifestyle or their diet or whatever as part of treating their ailment, or we don't help prevent disease or manage chronic disease well as traditional doctors, which, to be fair, patients come to us with problems. Right. So
exactly.
Initially, it's not the well who come and say, how can I optimize my preventative lifestyle? But I think what's interesting is that this is 1955, and this is exactly what Dr. Graham was doing, is he was looking at the whole person holistically, and this is a traditional medicine doctor.
Absolutely.
Pretty much. And he was
a traditional medicine.
He was a traditional medicine, and it wasn't like some weird like concept of functional medicine. This was part of what we learn and practice as traditional doctors, to look at the patient holistically It depends on what they're coming with.
Yeah, he considered this to be regular medicine.
Regular medicine. And that's what I'm trying to say. Functional medicine is not something special on its own.
No.
It's just regular medicine, but they've created this weird, it's not a specialty, but this concept where traditional medicine is flawed because we don't look at the patient as a whole, while actually, like this is another, there's many, so many examples of how traditional medicine does do that, and this is another example of that. So it does, the functional medicine is a little bit of an issue.
Yeah,
for
so
me.
I think the reason may be that medicine in general tends to focus on acute
that's how people present.
conditions, while there are plenty of people with chronic conditions, and he was a physician, of course, an internist, who cared about patients with a chronic condition, in this particular case being headaches. But I think you'll find that attitude among physicians who deal with chronic
disease.
Yeah, in general.
Yeah. In general,
it's not,
I know I do in my clinic.
You do too. So yeah,
that
seems
we
do the same thing.
There's not a lot of diet related to skin, though. That's people believe it is. But I mean, I don't usually specifically ask about diet, but that's because it's not relevant to the skin disease. While in functional medicine they believe it is, which it's not. But okay,
it's not relevant to headaches either. Although there's a lot of attention to that, and a lot of people are put on diets, even specific migraine diets. I've never really gotten. I've certainly applied those diets, but never really found that to be helpful. And I think I write.
You write that in the book, because I was actually going to ask that question. So, food in relation to migraine and headache. I mean, can you explain to us what you think about? Because this is something that I'm sure patients have come to you and said, "Well, what can I change in my diet to help my headaches?" And it's like, "Oh God, here we go again." So, how do you answer that question?
Yeah, so that's a very common question that comes up as well. And the first thing I like to emphasize is that it's much more important that you eat regularly than what you eat. So I'm a strong proponent of people eating 3 meals a day and not going without food too long. And that includes fasting for whatever reason. I think fasting, if you're a headache person, I don't want to say headache sufferer, if you're a headache person, you definitely shouldn't be doing that for any particular reason, because for sure you will end up with a major headache.
So intermittent fasting as well, like where you fast from like a certain fasting window from 6 in the morning to 6 in the evening.
Yeah, don't do that. And again, Dr. Graham also emphasizes that to eat regularly. He says that as well.
Poor meals, skimpy breakfasts and lunches and large dinners eaten in a state of fatigue are part of the errors in living. Just from 1955, but it still holds true today.
It still holds true. So that's the first thing I would like to say. And then, the couple of things I do ask patients to be careful about. For example, don't drink coffee excessively.
Yeah, 2 cups a day is what
maybe
you write
1 or 2 cups. 1 or 2 cups a day. And if you find, even when you drink 1 or 2 cups a day, and you find that if you do not drink those 2 cups of coffee, like in the morning, first thing in the morning, you end up with a headache, that is even too much for you. I found that a lot of migraineurs are very sensitive. They're sensitive to medications. They're sensitive to chemicals in general. They may also be sensitive to caffeine. So I know people who drink only like a half a cup of coffee a day, who tell me that if they don't drink that half a cup of coffee in the morning, they'll end up with a headache, and then it's too much for you. Yeah. So these people do better not drinking coffee at all, and that goes for caffeinated beverage in general, or like decaf coffee only. And then the other issue is alcohol.
So sorry. So if you have headache withdrawal, if you have caffeine withdrawal headaches, then the best way to manage that is to just make sure you drink coffee every day, but probably just to stop drinking coffee altogether.
Yeah, so one way to approach that is to drink coffee every day and make sure you don't go without it for too long. So that's also another reason with oversleeping, that you miss your first cup of coffee of the day and you may just end up with a headache due to caffeine withdrawal. Yeah. But no, I would prefer you then to further cut it down or maybe cut it out altogether. It just means that you're very sensitive to caffeine. Okay. And I don't think, headache is already a struggle in and by itself. Yeah. And you really do not want to make things worse. And so.
But decaf is okay.
Decaf. In all likelihood, it's better. Yeah, because of the fact that it has much less caffeine. And a tea, I think, is also perfectly fine.
So alcohol, you said?
And so alcohol would be the other thing. So limit your caffeine intake. Make sure that you don't experience headaches from caffeine withdrawal, which means that you're taking too much caffeine. But also alcohol, I think, limit your alcohol intake. Some men, the only thing they really have as a migraine manifestation is bad hangover headaches. Bad hangover headaches do not exist. If you have bad hangover headaches, these are migraine headaches triggered by alcohol.
Wait, so if you get a headache the night after a big or morning after a big night out, that's not a headache due to hangover.
If the headache is relatively mild, to moderate, it could certainly be a hangover. But you have people who get these terrible hangover headaches. They're sick for days after that, and these are migraine headaches, and you should treat them as such as well.
So they're not just from hangovers.
Yeah, but for example, also you have to be smart about it. For example, don't drink alcohol on an empty stomach. Make sure you eat first.
That's a general rule, I think.
Yeah, but still a lot of people, let's say on a Friday afternoon after work, they go out for a drink. They haven't had anything to eat since lunchtime or maybe since breakfast for some people.
Or they didn't have breakfast.
Or they might even have had breakfast. But and then they have some alcohol on an empty stomach, and then, dinner gets late and they go to bed later. And so, everything gets kind of messed up on a Friday evening, and then people wonder why they have a migraine headache or a headache that weekend. It's just
This is why I don't go out on Fridays.
And that would be a very good thing to do.
Or Saturdays. Or any other day of the week.
I think it's good to go out sometimes, but...
I think regular sleep schedule is more important to me.
But again, that also comes through in the book. Also, Dr. Graham writes about that.
That's part of the errors in living is if you don't have a regular sleep schedule, that's an error in living as well. And I agree with that one.
And I would also say that when you feel tired chronically or you feel tired a lot, the first thing you should look at is your sleep. Because I think myself that lack of sleep is probably the most common cause for people to feel tired chronically.
So, lack of sleep. But what I thought was interesting in the book, and you also go on about this a lot as well, is that fatigue due to lack of sleep, because that's really the main cause of fatigue, is you have lack of metabolic energy. And what I found interesting is I kind of knew this because you told me about this before, but I never had it written down.
At home it was kind of dinner table conversation.
Yeah, exactly. So I wasn't like taking notes, but when you described the book, I'm like, oh yes, that's what you've been telling me for a long time, and I just never super paid attention. Oopsie. But about the postural muscles. So, because I get bad neck, shoulder, back pain when I get fatigued. And so I know I'm tired. Well, I know I'm tired through various mechanisms, but one of the big ways is I get like this, this tightness in my shoulders.
Your muscles become tight.
And and what everyone says to me when I have that is, oh, go get a massage. And I was like, and I never found that really was helpful. But then when I read the book, I was like, oh yes, that's why. Because I know why. Because your postural muscles are your first to become tight when your metabolic energy is low, because you need energy to relax muscles.
Right, exactly.
So if you need energy to relax muscles and your muscles are tight in your postural muscles, because they're the ones that hold you upright, like jaw muscles as well, neck, shoulder, cervical,
neck, shoulder, upper back,
and like calf muscles. I never get any calf muscle pain, but fine. But even though I wear heels all day.
People tend to get cramps.
Oh, cramps. Oh, yeah.
Muscles. They may have another problem that's called restless legs syndrome from tight.
So I kind of skipped that section.
Yes. No, that's perfect.
So when you get the back pain, the from kind of holding your head up basically, and that cervical spine discomfort and your upper traps, then massage isn't really the answer, because the only way to deal with that is to get more rest.
Yeah, to get more rest is the way to prevent it.
Is the way to prevent it. But then but how do you fix it if it's there? Because you also write that tight muscles in your postural muscles can make it hard to sleep, which I've had that experience as well.
It's a vicious cycle.
Yeah, so then how do you fix that problem?
So what I like people to do is use a heating pad.
Oh my God, here we go. The heating pad.
A microwavable
heating pad. Do you know how many heating pads we have at home? And like the answer to every problem was, we'll just use a heating pad. And we have all these with the drug back in the day, they had the drug company names on them.
Right, exactly.
So we had the drug company name on the heating pad. We'd stick it in the microwave, like a bunch of beads. And then the answer to every ailment when I was a child and teenager was,
use a heating
pad.
But that's because a lot of ailments are muscular or musculoskeletal ailments. So tight muscles is extremely common. You can basically have it anywhere in the body, but it tends to be most pronounced in the neck, shoulder, upper back, the jaw muscles, the lower back, and the calf muscles, and people have complaints about it. And what I strongly recommend, so if you have headaches frequently, if not daily, and it doesn't really matter whether that's migraine or not, people invariably have tight muscles, neck, shoulder, upper back, because I think that drives the frequency of headaches. And I found under those circumstances, using a heating pad on a daily basis, applied to the neck and shoulder muscles, using it preventively, I think is really the best way to go. It's something you can do yourself. It's cheap, which is important because I'm, after all, a Dutchman.
Yeah, we need to everything has to be cheap.
And the issue with massage is that massage is great, but especially when it comes to the neck, shoulder, upper back muscles, has to be done very gentle.
Yeah, and I think that's where a lot of this goes wrong. Like the massage therapists are like, that's, you want it to hurt. Like,
No, you don't.
You don't. So I've always been not a fan of painful massage.
No, and it shouldn't be.
It shouldn't be painful. Even like as an athlete, like everyone's like, oh, regular, what they call body work in the world of bodybuilding. It's not called massage, it's called body work.
Oh, really?
Yeah, I'm like, I don't know, whatever. But I was like,
massage is maybe considered luxury.
yeah, it's luxury. Yes, exactly. We can't have any luxurious things happening in this sport. It has to be hardcore.
Nothing in that world.
Nothing in that world. So, and I have had people ask me, never ending, like, how much body work do you get per week? I'm like, nothing, because I just don't feel like massage does anything to help me as an athlete. But it doesn't really do anything for it just makes my muscles hurt more.
Yes,
and that's counterproductive.
You have these physical therapists or massage therapists to even try to do that with their elbows.
Well, they walk on you.
They walk.
Massage.
They walk on you. They may walk over you as well.
Yeah.
But no, I'm not a proponent, a fan of that at all. Of course, I like to use physical therapy in my patients, but for example, I will always use physical therapists who I have experience with. I know they do a good job and they know how to treat headache patients. And that means you have to really do that very, very gently. Use heat, massage, gentle massage, maybe gentle ultrasound. These are the kind of things, but nothing
painful.
Nothing painful. And you have to also stay away from excessive stretching, especially stretching the neck to the side or rolling it around. These things are really no good.
It's like a Thai massage, through and through. They walk on you, then they stretch you.
Yeah. So, again, I think as far as I'm concerned, the best way to go about it is to get yourself a very nice microwavable heating pad.
It's like $10.
And a little more expensive maybe than that. One that fits very nicely over your shoulders and also includes the neck and the upper back.
Yeah.
And use it every day for sure, 15, 20 minutes at a time if you can do it in the morning and in the evening. Because what happens is that a lot of these patients who have chronically tight muscles, during the night, these muscles are supposed to relax, but they don't.
They don't.
And you may be lying in a little bit of an awkward position. So in the morning, the muscles tend to be tight because of inactivity, so you use it in the morning, and then of course as the day progresses they tend to get more tight just from the wear and tear of the day. So do it in the evening before bedtime. And it is a vicious cycle in the sense that to be able to sleep you have to relax your body and your mind. And relaxing your body means relaxing your muscles. And if your muscles are chronically tight, that's going to be difficult. And I think, as I also write in my book, that chronic muscle tightness may well be the number one cause of insomnia.
Yeah, you're right that too, because there's lots about insomnia. But
there's also a lot about insomnia.
What I thought was interesting was the explanation for this, because you're right. The postural muscles are the first to become tight when the body copes with the lack of metabolic energy because they work the hardest to maintain our posture. When muscles are tight, they interfere with their, I'm going to say this again. When muscles are tight, they interfere with their blood supply, creating a vicious cycle that further deprives them of metabolic energy because you need a blood supply to bring the energy to the muscle.
Exactly.
So if they're tight, you're literally restricting the blood supply, causing more muscle tightness over time because you deprive the muscle of metabolic energy because the tightness causes the blood supply to decrease.
Right.
And then it's like the interference with blood supply also causes the waste products that the blood ordinarily washes out of the muscles to accumulate. So, because when your muscles are tight, you produce more waste products. Lactic acid from
lactic acid,
which causes the discomfort.
Irritates the nerve fibers.
Yep. These waste products are acid. Lactic acid, and the acidification of the tight muscles renders them sore and tender due to irritation of the pain nerve fibers that run through them. This in turn creates a vicious cycle of its own, resulting yet in more muscle tightness over time. So I'm like, I learned this from you, like what's the root cause or what's the explanation for the problem? And I try to do that with my own specialty, but you do that here. Because I never thought of it like that the tightness of the muscles is restricting the blood flow, which is stopping the blood supply, which is meant to bring the energy. Yeah, because that's what blood does. It brings oxygen to tissues, and it removes the buildup of waste products.
The waste products. Yeah.
So that's the explanation. So if you have tight muscles, then trying to alleviate that through relaxing the muscle with the heating pad.
Yeah, the heat basically just improves the circulation. So I don't think there's anything magical that heat does. I think heat improves the circulation of the muscle.
So what, like sauna?
heat doesn't penetrate very well. I write about that in my book as well. So, a lot of people will tell me when I tell them, use a heating pad on a daily basis, get a nice microwavable one and so on. They say, oh, doc, but I take a hot shower every day or every morning, or I take a hot bath. Okay. That's just not enough. Heat doesn't penetrate very well. So you really want to make sure that you have that's what I like about those microwavable heating pads, because they tend to be heavy.
You should make a line of microwavable heating pads and sell them, because that's not a bad idea, actually.
What Vaseline is for you is the heating pad. Is the heating pad for me. So maybe we should put some package together.
Yeah, we should. Vaseline and a heating pad together. That's all you need in life.
Exactly.
But yeah, I mean, I think because I don't like the faffing around of microwaving. So I used to have electronic ones, but you didn't. You told me not to have the electronic heating pad.
They don't fit that nicely, and they don't create as good a contact.
But I'm too lazy to microwave. Okay, fine. And then I also got, because I can wake up with neck tightness too, so I got one of those pillows that's like a massager.
Sure.
So I use it before I go to sleep, but it's not massage that's painful. It's like
gentle.
a gentle.
Yeah,
so
that's fine.
I lie on it because it turns itself off after 10 minutes. So I lie on it to help me fall asleep. And then I put it on again in the morning before I get up to like relax it again. This is when I'm really bad. But I try to prevent that from happening. And then I also have one I can wear while watching TV.
Yeah, no.
It's gentle massage.
Yeah, as long as when do you know whether the massage is proper for you? For your body, it's if you feel better after that and don't end up with a bad headache. The issue is that...
Or more pain.
Or more pain. Yeah, you don't want to end up with more pain, more muscle pain, and you definitely do not want to end up with a bad headache from it. I mean, you can even get that from... there's a particular relaxation exercise. It's called progressive muscular relaxation. You lie on the floor and you make your muscles tight before you relax them.
Push your head back out.
And then you do that with your neck as well. So you press the head against the floor and you bring your neck muscles in spasm. And I have seen migraineurs who were admitted to the hospital and were getting their daily physical therapy, including relaxation, to end up with major headaches from that. And the physical therapists were wondering, what is going on here? But it's the particular relaxation exercise that does it.
That's the problem. But I get migraines every now and then, but I'm not a migraine sufferer. Like I haven't had a migraine like over a year. So, and it wasn't something that was, I had my sumatriptan tablets somewhere in my medicine box somewhere just in case, but I haven't had a migraine in a long time. But for me, like I get a lot of this neck stiffness. And when I go to the gym and I do my normal training every day, trim my upper body, and then it gets better. But then in a few hours, it'll get worse again. Like it'll come back worse. Is that because I've exercised and it doesn't really fix the problem?
I think so.
Makes it worse?
And I know you do the weightlifting, but that's the one exercise I discourage patients from doing. I tell them it's fine to do that with the lower half of your body. But when you have chronically tight neck, shoulder, upper back muscles, you really don't want to be weightlifting. If you want to do weights, I tell people to do light weights and make sure the emphasis is on range of motion. So making sure you stretch well.
Right. Okay. So that goes against.
But I've also seen, for example, football in the United States where I practice. Football players,
like American football.
American football, they have shoulders like that, and they get what are called burns. I'm not a sports person, so I don't really know, but that's what I think I've learned from those guys.
A
burn? It's called a burn in the shoulder. It must be severe burning pain from the muscle tightness. And I've seen also these American football players coming in with very bad headaches from that as well.
Probably have it from
so.
Okay.
I mean, whether you get bad headaches from that really has to do with to what an extent you are burdened with migraine genetics. So if you have an occasional migraine, your migraine genetics burden must be relatively low.
Yeah.
But when you have a bad burden, especially, for example, when your father has migraine, I don't have migraine.
No.
But under those circumstances where the father has migraine, you very often find a significant headache burden in the offspring. And so that's where you tend to find your worst headaches.
So that brings us to the subject of genetics and migraine. So having the ability to have a migraine, and a migraine is defined as a headache by a severe headache, defined by intensity, but also its inability to respond fully to over-the-counter medication, and that's obviously in the book. So that's kind of how we define headache, and then you can
one way of defining
one way, because people always, I didn't have a migraine because I didn't throw up. I'm like, I don't think that's diagnostic.
No, that's not.
So, but you don't have to throw up. You don't have to be sick. You don't have to kind of have these symptoms. You don't have to have the kind of visual disturbance, the aura. You don't have to have that. But if it's severe enough where it's not being treated by a little bit of Nurofen or paracetamol or aspirin or whatever you're taking, or it's only partially better, then you probably are having a migraine.
Yeah. So we all get headaches, but these would be ordinary, regular headaches. You may call them tension headache, tension type headache, muscle contraction headache. There are a variety of names for it. But these are the kind of headaches that are mild or mild to moderate. At best, you definitely are not incapacitated because of that. You don't get sick to your stomach because of it. And, rest, relaxation, maybe taking a couple of Tylenol or aspirin, whatever you want to do, would relieve that. If you have anything in terms of headache that goes beyond that, and certainly if it makes you sick to the stomach, although that's definitely not necessary. You have migraineurs who just have terrible headaches. They don't get
pain.
light or noise, terrible headache pain.
Yeah.
They don't get light or noise sensitive. They don't get nausea or vomiting with it. And these people are very often not even diagnosed as having migraine because we have, what we call international diagnostic criteria, which are really for research only, but they're being applied to practice. And they say if you don't have headaches that come with light and noise sensitivity, or if you don't feel sick to your stomach, you don't have migraine. Nothing of that is true. That's really
intensity.
Medicine going wrong there.
That's great. Those aren't all the time. And then about the father having had migraines. So this is a good question. I think a lot of people think that men don't get migraines, but men do get migraines.
Oh, absolutely.
And that's what they mistake as a hangover headache.
Yes, and I tell you, preteen. So before the teenage years, headaches in general, including migraine, is even a little more common in boys than it is in girls. I mean, the difference starts to occur between the genders when girls start menstruating.
So that brings in this, because there's an interesting section in here about headaches in children, which I didn't really know anything about until I read that section.
You didn't learn anything about it in medical school, I would assume,
right?
No, I
did not. And which is
you're not the only one,
I'm clearly not the only one. But it was about that something phase. I didn't write this down. Because I think there's a lot of people watching this who have children, obviously, and that when you have headaches in children, by children, what age are we talking about? Like before the ages of 16 in this context? Children with
before 10?
Before 10.
I mean, maybe before 11, 12, because, in the early teens, of course, then girls start to menstruate, and that creates a totally
whole
different...
new thing.
Oh, yeah.
So children. So before that, what is that called? I can't remember. That something phase sleep thing in children.
Oh, delayed sleep phase disorder that you find. But that's in mostly teenagers and adolescents.
Oh, okay. So but we're talking about headaches in children under 10.
Yeah.
So if your child under 10 has headaches, there are red flags you look out for, because that's kind of unusual.
Yes. So, so headaches certainly do occur in younger children, let's say below the age of 11, 12. Before teenage years, preteen. But they tend to occur relatively infrequently. They don't tend to be terribly intense, although these children may get very sick with them. And sometimes they even have, a predominance of stomach symptoms, like feeling very nauseated, throwing up, maybe even in explosive kind of way, and also may even have abdominal pain. You call it abdominal migraine. Maybe that's the term you were looking for.
No, I was talking about the dual phase, the phasic sleep disturbance.
Oh, the delayed sleep phase disorder.
But so what should you, if you have an under 12-year-old and they start getting headaches maybe once every couple of weeks?
Yeah, first of all, you do need to take that seriously.
Yeah.
And there's one thing with children, if they do wake up with bad headache in the morning, or they are woken up by headache at night, that really needs urgent medical assessment because, typically a brain tumor would present itself that way in children. And so in children? In children, not in adults.
Not in adults,
children.
In children.
So waking up with bad headache or being woken up out of sleep with headache is certainly a very bad presentation in a young child.
Under the age of...
As we get older, for example, as a migrainer gets older, it becomes more and more common to wake up with bad headache in the morning or to be woken up out of sleep. But I'm talking about, let's say preteen children. So and then also, I really don't like to treat children of that age with pain medications, for example. I like antihistamines under those circumstances. But
that's if you've ruled out anything sinister.
I'm sorry?
If you've ruled out something.
Yeah. And you generally don't need to worry about that unless you have those kind of presentations that are red flags in childhood. Again, I can't emphasize that enough. First of all, you always need to take things seriously. Children don't pretend.
Yeah, no.
They're sick with a bellyache and throwing up. They don't pretend that way. You need to take those things seriously. Don't feed them with pain medications if they complain about headache. I like, as I mentioned, the antihistamines, especially the ones in liquid form, like a syrup that can be given to a young child. Once a young child goes to sleep, very often, 1 or 2 hours nap will then eliminate that headache, which is also different from the adult. The adult generally needs overnight sleep for a headache to be resolved, but anyway, that's kind of the story.
Yeah. So children headache. So if you have an under 12 and they start getting headaches, take it seriously. Get them to see. We'll probably take them to the emergency room or go.
No, not to the pediatrician. I'm not a fan of people in general going to emergency rooms. You generally don't get the best care there,
unless you're about to die.
Yeah, unless something
seriously terrible is happening.
Yes, but certainly not for headache. It's generally the worst place to be when you have a bad headache.
So not the ER, but the next day go to the pediatrician.
Yeah. Talk to the pediatrician anyway.
So then we can move on to that. So you wrote, if you have headaches as an adult, so we're going to move on from children to adults. As an adult, what doctor should you see? Now you wrote about this and I got a little bit pissed off when I read this.
Really?
So I was like, what are you saying? Like, I had not read this book before you published it. And if I had like done an editor role in this book, I would have said you're removing this entire sentence. So on page 34, and I put big question marks next to it because I was like, what is this? So you wrote, with a complaint like headache, people tend to go to a neurologist, referred or not, but I do not recommend that.
Right.
And I'll finish in a second.
Okay, go ahead.
I always say with dermatology, like, if you have a skin problem, see me first. Go to a dermatologist.
Okay, there's a reason.
Yeah, I'm going to talk. So don't mess around with any other doctor. Let me just deal with the problem. It'll be much easier for you and for everyone else. But anyway, so continue. The reason, so you wrote this. I do not recommend that. The reason is that neurologists generally do not consider the medical cause of headaches and focus on the neurological brain-related ones only. So you wrote, Nevertheless, I think that the initial consultation should be with a primary care physician, GP, or family physician. But like, this entire book is basically about the non-neurological cause or the non-brain related causes of headaches. You clearly look at everything. Yes.
So my book is not a neurological book about headache. It's a medical book about headache, a general medical book about headache. And certainly neurology fits in that. And I do talk about neurological causes of headache.
Yes, there are in there as well.
But I put them in, I think, the relevant perspective, because neurological causes of headache are very, very rare, especially considering how prevalent headaches are to begin with. And what people often forget, or maybe always forget, is that there are common medical causes of headache, such as anemia,
you were that,
iron deficiency, low thyroid function. And there are patients who I treat solely for those medical conditions. Also, for example, reflux, GERD, gastroesophageal reflux disease. I have treated migraine patients preventively just with what we call a proton pump inhibitor, like omeprazole, because they had reflux triggering the headache. Or I've treated patients for their constipation because they found that every time they don't have a bowel movement for 2 or 3 days, they end up with a bad headache. And so this really brings me to, that's of course the other reason I wrote the book. And I think that has to do with the fact that although I'm a neurologist, I trained in headache management with an internist, but also I myself have training in pharmacology, I trained in neurosurgery, I trained in psychiatry. So I have a relatively broad education, and that is certainly something that I did to a certain extent, specifically because of the interest I had developed walking at Dr. Graham's hands in this particular field.
Yeah, so I think don't see a neurologist as your first protocol, except if you're seeing my dad. Just see him first. So you don't need a referral. You just email. So you don't need a referral. But I think it's more, so don't misread that section because that makes it look like you shouldn't see a neurologist. I think
you should see a neurologist if you have, for example, if your headache is associated with seizures or the headache is of a very acute onset, or if you have other issues that certainly tend to point to a neurological problem,
but you're saying
a
that
brain problem.
Primary care, GPs, and there are many excellent PCPs and GPs and internists, but not all of them would probably be as good at, I mean, just like there's bad accountants, good accountants, bad everything, good everything. So you'd have to find the doctor who understands headache enough to be able to do all those underlying medical investigations. So if you're a primary care physician or a GP and you don't know a lot about headache, just read this book, and then you'll know what to investigate your patients with if they come with headache.
And it is relatively simple. For example, also high blood pressure. I didn't even mention that, but
pretty simple.
Very often people will say, they go to an emergency room with a bad headache and then they find the blood pressure to be high. They will say, that blood pressure is high because you have a bad headache. No.
It's the other way around.
You need to treat that high blood pressure. Don't make certain assumptions. There's also no basis to make those assumptions. But, not only doctors do that, but also patients do that. They say, I feel tired because I have a headache all the time. No.
It's the other way around.
You have a headache all the time because you feel tired all the time. Let's look at that. Let's look at that in terms of your lifestyle, but let's look at that from a simple medical perspective. Let's look at, your hemoglobin, your ferritin, your thyroid function.
Yeah, so
all of those kind of things.
Just see the right doctor.
Read my book first.
Read the book first, then choose your doctor.
That's why I put it in a hardcover, because I hope that people will read it and take it with them for a medical consultation.
Doctors love that.
I know doctors love that.
So I read this book, GP, and I want this and this and this. Yeah, doctors love when you do that. People do that with my book too. I'm like, okay, don't do that. You'll just make all the doctors hate me. So, I saw in this book.
The good doctors will appreciate any help that they. So if you run into a doctor who gets upset with that kind of an attitude, I certainly can understand it when you come with a printout from Google,
or like a TikTok video,
but not a book like this, or your book, Skintelligence, written by medical professionals.
When someone brings me like an Instagram or a TikTok post, then I'm like, oh God, here we go. Anyway, moving on from that. So that brings us into the concept of the menstrual cycle and headaches. Now, there is something from page 28 I wanted to draw your attention to. You're right. So women can get a headache around pretty much any part of their cycle. So premenstrually, postmenstrually, mid-cycle, time of ovulation. Like it's basically any time. So
no.
Well, that's how it read.
But that's maybe how you read it.
I read it. Yeah. It is so significant. So you say that despite the fact that it is paramount in the context of migraine, like the menstrual cycle, its underlying mechanism is not known. It is so significant that I would say that if we understood why women experience headaches in relation to the menstrual cycle, we would have a handle on at least half of humanity's headache suffering. So, and you say that really the culprit is estrogen or its various forms.
Estrogen. Estrogen hormones in general.
And that's the culprit. So then you, very interestingly, where's the other page? Say that because you're not a fan of estrogen-containing birth control.
Correct.
So, and then you talk about the different, I don't know where that is anymore, different forms, but tell us a little bit about estrogen-containing birth control. And by that, we mean the combined pill.
Yes, the combination. The regular birth control pill. Which has both an estrogen hormone and a progesterone hormone in it.
Yeah.
And what I say about estrogens also relates to menopausal estrogen therapy. That's coming back.
It's a whole new problem.
It was gone for a long time, then it came back, and then it was gone again for a long time, and now more recently it's coming back. And of course, that makes my heart ache.
Yeah, but I swear, every woman in my age, like I'm 44, right? In my age category above, who has even a sniff of a symptom of menopause, even just a whiff of anything, is put on HRT. And they're always given estrogen. Yeah. and they're almost always given progesterone. Because you said something, I need to find this quote because it was epic. I don't know why I didn't
But let me say here that if
page 41.
If you're on hormone replacement therapy, HRT, and you tolerate it fine, as far as I'm concerned, there's nothing wrong with that, although I still wouldn't recommend that because I do believe that estrogens present a risk factor for breast cancer and cardiovascular disease. But if you don't believe me, that's fine. As long as you don't get headaches from it, of course, it's up to you.
It's up to you. And I think you wrote this here, page 41. So any menopausal woman who wants to get really pissed off, you can read this sentence. So this is about menopause. So when women take HRT, so the amount of estrogen in your HRT is about 10 times less than in the combined pill.
Yeah.
Right. So you're already taking not a lot of estrogen, but fine. There's been a resurgence in the use of estrogen prescribed for the treatment of menopausal symptoms, particularly hot flashes and night sweats. What these doctors often fail to mention to the patient is that such treatment is merely postponement of execution, meaning that after you discontinue or stop taking your estrogen therapy, so your HRT, the complaints return. And you wrote, oh my God, I can't believe I'm reading this out loud because I'm going to get such negative press for this. I am not saying this. This is a quote from the book. I did not write this book. I think that and this is written by a man. This is not written by me, obviously. I think that it is better to cope with them as best as possible, the symptoms of menopause, and wait it out, knowing that they will ultimately improve, although this may take anywhere from months to years.
Yes.
So that is a very bold statement written by a man in the current climate of menopause, where women are adamant that they should be able to live their best life, and HRT helps them live their best life despite going through menopause.
Yeah, I'm not exactly sure that it means living your best life.
Well, that's what we're sold to believe. If you suffer
from headaches daily, I don't think that's living your best life.
Definitely, because I'm also reading this as like a general health thing, not just for headache. I think, would you say the same for women who don't have headache?
I said that already. I said that already. I mean, I am a strong believer that estrogens increase the risk of breast cancer, increase the risk of cardiovascular disease. I think women are better off without it. And that's also based on my medical training, which goes back to the 1970s. So already back then, it was strongly believed that estrogens were not good for you from those perspectives. But you've failed to read what is next there in that section. And that is that, for example, if you have disturbed sleep from night sweats or hot flashes, then you should get that treated. I think insomnia is a very big issue, and we should treat that.
Yeah. But most women don't not sleep because of hot flushes and night sweats.
Right, they have problems sleeping.
No, but they don't cause you not to sleep.
They do. No, they do. Night sweat, hot flashes interfere with sleep. You may not have experienced that yourself, but that's certainly a very common complaint. But also other symptoms that relate to menopause, I think they should be treated. I'm not saying that women should suffer. I'm totally against that. No, but I think you shouldn't make your health condition worse, especially if you are prone to headaches, by using estrogen replacement therapy. I think under those circumstances, it's better to wait it out, because the issue is once you're on HRT, it's very difficult. I have found it very difficult to get patients off that. It needs to be tapered down very slowly. And
so to put that in context, when I read it, I was like, oh my God, this is going to piss off so many people.
Yeah, but you need to continue reading.
Well, I did continue reading, but I still didn't.
You still didn't get that. But no, I'm not a proponent of suffering at all.
Yeah, we don't like to suffer with menopause, so
or
do take
not.
your HRT.
But I do think I think there are other ways of dealing with those symptoms that doctors also don't do. For example, lots of people have insomnia problems. They may have been to their, primary care physicians, and they very often leave the office without any help. And I'm not a proponent of that. I see that also in psychiatric care. People that have bad anxiety, depression, don't sleep at all. They give them antidepressants or anti-anxiety medications, but nothing for sleep. I think I mentioned that in the book as well.
A couple times, yeah.
Yeah, that psychiatrists also need to pay attention to those issues. And I think when you treat a patient, you need to look at the entire picture and basically try to find the treatment that covers a number of those issues. For example, if you have a lot of anxiety, depression, and you have insomnia, you need to use anti-anxiety, antidepressant medications that also help you sleep at night. That you basically cover that as well.
Yeah. So, I mean, you talk about trazodone a lot, which is a type of antidepressant, but it's not used as an antidepressant really anymore, but it's very good for sleep. I take trazodone on your advice because I had trouble I have trouble staying asleep at night.
Yes.
And it's taken me a while to figure out what dosing should be and everything, but I think it does really help. So, because I've basically taken everything that's talked about in this book. That's also when I was reading, I was like, and yes, I take that. And I wonder why I take that. So I had never even heard of trazodone before you mentioned it a few years ago. And I was like, what drug? But so when you read this, you'll be like, oh, yes, that's a drug I've never heard of. If you're a doctor reading this, I recommend it. If you're a doctor, read it. You should read this anyway, especially if you're a PCP or a GP, because you'll see things that you haven't seen before. But one thing, I remember when you were writing this book initially, because I have tons, like hundreds of references in my book, and I was like, how many references do you, and what did you say to me when I said, what reference? There are no references in this book.
No references at all.
So why are there no references?
Because it's all based on my knowledge and experience. Of course, I'm in a little different situation than you are. You're quite a bit younger than I am, and you haven't practiced medicine for that long, but I'm sure that, give it another 10, 20 years, you write a book without references as well. Either. And also, I really, I have published, I think maybe a dozen books. So this was not the first book I wrote, but these books were all written for the medical professional, and so they have references. Yeah, they were also written in a different way, in the sense that, like you wrote your book, you made a very extensive outline, you got the references. That's what I did for all the books that I've published to date. This book I really wanted to do differently. I wanted to just write a book. I'm not an author, but I just wanted to write a book, and didn't make an outline, didn't look for references. I basically just started writing it, and it kind of went from one chapter to the next. So the concept, I had never really, until you started working on your book Skintelligent, and I read the manuscript. That's kind of, I don't know why I had never thought of it myself to write a book for that. Maybe because I'm a medical professional, I feel that what I write should be for my colleagues to educate them.
Because I would never write a book for other dermatologists. Like, it didn't even occur to me to write like a textbook or like to be involved in the textbook. Yeah. Like, it would just be like, oh my God, I can't do this. Like, I do not want to write a book for like other doctors. I just don't feel like I have the knowledge that I would need to be able to write a book for other doctors. Though there's a lot of doctors who read my book who found it very helpful.
They should read your book.
Yeah, especially if you're prescribing hydroquinone. Just as an aside, read my book. Yes. But I think maybe in like 10 or 20 years, I'll also write a book with no references. We'll just hold our breath for that. But yeah, so there's no references. If you're thinking about references, like where did he get this idea? Just look at the other 12 books, which you can also buy on Amazon.
Yeah, some of them are still available. Others are so old that I wouldn't bother.
Don't bother. But the references are there. But so yes, the thing with menopause is a bit. It's not confusing, but it's more nuanced than I had initially read when I read this. But yes, if you're suffering from menopause symptoms, do treat that because you shouldn't suffer, especially if it disrupts your sleep. Anything that disrupts your sleep is bad. Yeah, especially if you're a headache sufferer.
And let me just add something to it. That I think a lot of menopausal symptoms or symptoms that are attributed, complaints that are attributed to menopause, in fact, have nothing to do with menopause. They have to do with the development of low thyroid function, hypothyroidism. Yeah. Hypothyroidism is quite common, especially in women, and tends to develop between the ages of 40 and 60. And I certainly, in my practice, have taken people off HRT, hormone replacement therapy, and instead of that, given them levothyroxine to treat their low thyroid function with resolution of their symptoms.
So this is interesting because I recently had a patient myself who, 44-year-old lady, she'd had 2 viable pregnancies, naturally conceived, and then she wanted to have another child, and she'd had 2 miscarriages in the course of a year. She was feeling fatigued. She had trouble losing weight. All the symptoms that you kind of expect of someone who has 2 children, is in their 40s and works full time. So that wasn't weird. Not that the miscarriages obviously were not normal, but generally fatigue. She came to see me for general anti-aging concerns, so nothing very specific. But when I took her history, she said, trouble conceiving now, weight issues, generalized fatigue, feeling very stressed, so on, so on, so on. I said, well, anything else happening in your medical history? And she said, well, I've had blood tests recently. I had a TPO, anti-TPO antibody, thyroid peroxidase antibody, over 1,000.
Oh, wow. Hashimoto thyroiditis.
Yes.
Hashimoto's disease.
Her TSH was slightly elevated, but not terrible. And her T3, T4, I can't remember, but I think they were roughly normal. And she had seen like a functional medicine some wacko doctor who gave her some kind of a thyroid supplement or something. I don't really know. And I was like, well, why don't you see a real doctor? So I sent her. This always goes down well. So I referred her to an endocrinologist, a very well-respected endocrinologist, and she saw her as well. They did a liver ultrasound. They did she did thyroid ultrasound. Inflammation was seen on the ultrasound.
Or nodules.
Yep, I think nodules, perhaps inflammation. But she did not treat her with thyroxine.
Yeah, and that is a major issue as far as I'm concerned.
Yeah, so this is weird because I was like, hold up. I said, no, she needs treatment. She needs to be given something. And when I queried this to another colleague of mine who's an internist, I gave him the story exactly the same. I said, should she not have some type of treatment? He said, no, in the guidance given about this type of situation, because I'm not an endocrinologist, I don't know the guidance, I haven't read the guidance. The patients, we don't treat them with thyroxine.
Yeah.
And I was like, that doesn't sound right to me. And then when I read the section in the book, I took a photo of it and sent it to my colleague who's the internist. Like, this is why I said she needs treatment. Because I know from talking to you, like around the dinner table, that these patients need treatment. But I didn't know where I had gotten the idea from. But yeah, so you would treat her.
I would definitely.
Type of scenario.
So the issue is that people look at the TSH exclusively, the thyroid stimulating hormone level exclusively. Yeah. That is, as far as I'm not even an endocrinologist, I'm not even an internist. I'm a neurologist, but I would say that's very old-fashioned medicine. And if you have an elevated TPO-A level, treating a patient like that with levothyroxine may even bring down your TPO-A
and you wrote
level.
That in the book.
Yes, I think in about half of the patients where I proceed that way, and even just recently, and this lady who's, I think, early 60s, her TPO-A level was only 14, so that's not even that much elevated, but I put her on 50 micrograms of levothyroxine. The thyroid hormone went down from 14 to 6. Did she feel better? And she felt better. She said, I feel normal. And I said, what do you mean feeling normal? What does that mean? She said, I feel more like myself. Okay, whatever that means. But she said it must be from the levothyroxine, which I think is true because thyroid function regulates energy metabolism. It's essential to every single cell in our body that we have a good supply of metabolic energy, not just for the muscles. And you talked only about the skeletal muscle, but think about the gut muscles.
Yeah.
And there's a lot of talk about the stomach and the large bowel in my book as well. It really takes, covers medicine, or a good part of medicine anyway, as it relates to people's health. But yeah, I think it's very important, and I think we really need to revisit that. I also look at that in relation to pregnancy, for example. This lady who had the miscarriages, I would swear that she had the miscarriages because of her thyroid function.
Yeah, and that's what I thought too,
or
just because this is
infertility.
Dinner table conversation. I was like, I remember you telling me about patients about this like 5 years ago who had the same kind of situation. But when I spoke to my internist colleague, he was like, there's no evidence to suggest that her miscarriages would not have occurred if she was on treatment. And I was like, yeah, I think that they would have. So, though I have no...
Yes, there is no evidence.
There's no evidence.
That's not part of medical practice.
No, it's not just about evidence.
No, it's certainly not. Like you, I'm a supporter of evidence-based medicine, but not in the way it is being used.
Now.
The evidence comes out of clinical trials, and clinical trials are totally... I'm a pharmacologist and a clinical trialist. I have a lot of experience conducting clinical trials. These clinical trials have nothing to do with the reality. Of medicine, and we're using the outcomes of these clinical trials to put together guidelines. I am a supporter of evidence-based medicine, like you are. We want to make sure that we do things that are safe and well tolerated and have proven efficacy, but I'm not a fan of guidelines at all. No, I think guidelines make everybody stupid and provide bad medical care. So if any doctor comes up, or any healthcare practitioner comes up with guidelines, go for the door as fast as you can, because I think the ultimate output is going to be bad medicine. And you see that in headache also. We have the International Headache Society classification. with diagnostic criteria for migraine that make no sense at all, that the migraine headache has to last between 4 and 72 hours. Who says that? What is the evidence? There's no evidence. These diagnostic criteria were put together for the purpose of clinical trial research only. Because we need to, we do these clinical trials globally, a lot of different centers in the world working on those things, and we need to use the same diagnostic criteria, however arbitrary they are. We need to.
But I mean, I get this a lot because, like, there's not studies of everything. So I use a lot of oral minoxidil for hair loss. And I had a couple patients yesterday say to me, yeah, but how much should I take? Or is it better if I take more? I'm like, no one knows the answer to that question because it's never been studied in a clinical trial. But from my clinical experience of using this for the past 10 years, I would say a slightly higher dose in men gives them a better result. That's not on paper. I don't have any like nifty little charts to show you, but it's just from having treated patients with hair loss for 10 years and just paying attention.
Exactly, paying attention to your patients.
Just pay attention to the patients and just see
which
them.
I've done.
Which you
do that too.
I pay attention to the patients, and then ask them, how do you feel? How is this? How is this? But I mean, the guidelines drive me insane because there's always new, for dermatology, definitely, constantly new guidelines. And I'm like, oh, Natalia, you're not following the guidelines. I'm like, yeah, but the guidelines are guidance.
Yeah, so they're not rule. These guidelines don't drive me insane because I don't pay attention to them.
Okay, so unfortunately,
but that's also because I'm older and can allow myself to do that. So
I have to still pay attention for another maybe 5 years, and I'll stop paying attention when I consider myself sufficiently old. But speaking of guidance, you talk about reference ranges for blood, and this is a really big topic, especially right now where the trend is that there's people who call themselves these terms are like blood analysts. This is a thing. Yeah, this is a thing.
Oh, really?
So, and they're usually personal trainers or someone within the fitness industry or fitness or health related kind of thing where they call themselves blood analysts. So they have clients who come in, they request a bunch of blood tests for them, and then they analyze the blood tests. These are not medically trained people. They're not doctors. They're not even nurses. They're not people who can request blood tests.
Not medically trained.
But they've done maybe a weekend course in blood test analysis or something. And they're claiming that they can give you medical advice. And I've seen this go horribly wrong because I have patients who come to me having had their blood work analyzed by one of these people who call themselves clinicians, which is also extremely misleading.
Yes.
It's not just a Dubai thing. It's a global problem.
Yes.
So now, but you talk about reference range, which in page 17, which I think just explain what a reference range is, because patients always come to me too, because they see their own results. They're like, oh yes, but my ALT, my transaminase, whatever, liver enzyme is slightly high. I'm like, yeah, I don't care.
No. I mean,
I'm not bothered. It's fine. No, but it's out. It's red. By 2
it's out
points.
Of the range.
It's out of the range.
Out of the reference range.
Slightly.
So these reference ranges are very often referred as normal ranges. That's the first mistake. And also physicians and other healthcare practitioners certainly tend to refer to it. And I even sometimes myself talk about it that way because we're so used to talking about it. But
that way.
First of all, with regard to anything, we do not know what is normal for you. And I think that's what we need to keep in mind. The reference ranges are always put together by the lab that
does the test.
Performs a test. And it basically covers 95% of the results of a large number of samples that they've tested. So it's something that is totally artificial. It only tells you that when they, let's say, look at 1,000 samples, 950 of the results from those samples will fit in that range. But that still means that 5% fits outside of it. And it's also assuming that it is what we call a normal range, and a lot of blood tests don't have a normal distribution. For example, certainly when it comes to thyroid function, because of the fact that low thyroid function is at least 5 times more common than high thyroid function. So you have it's lobbed towards the low side, and they don't necessarily take that into consideration. So you really need to look at the results of blood tests in relation to the patient's health.
Yeah.
And for example, if you have somebody who has a hard time losing weight, feels tired all the time, is constipated, has coarse hair or whatever, all symptoms that may be related to low thyroid function, you need to really look at that. And also, I write it in my book extensively, you shouldn't just look at the TSH, That is an old-fashioned way of doing it. There has a certain background to that, but you also look at the free T4 level. So these are the two tests that I do, TSH and free T4. And if thyroid disease runs in the family, I also always look at TPOA, the thyroid peroxidase antibody, because Hashimoto's disease is a condition that runs in families. And so I take that into account as well. And I treat the whole picture, not just looking at the TSH, although I know how endocrinologists think about that. I've had discussions with, I used to be at one of the Harvard hospitals in Boston, and had discussions about that with the chief of endocrinology.
Yeah, they hate
whose
this
license
concept.
plate was TSH.
Was it? That's epic. I need to change my license plate to something cool. Okay.
To acne.
Yeah, to acne. No, mine should be Vaseline.
Vaseline,
Yeah,
yes.
Vaseline.
So, but anyway, so I know how physicians think about this, and I think that, and I mean, even as a neurologist, I would say that that's wrong, that people should really revisit that issue. And I talk about it extensively in my book as well, because I believe that that's what we should be doing, and not just treating patients based on the numbers.
Yeah, I mean, when I talk about, because I have had thyroid issues since I was a child, and when I talk about where I keep my TSH within a certain range, everyone's like, oh my God, do you see a doctor for this, or do you do it yourself? I'm like, yeah, no, I do see a doctor for this. So don't treat your family.
Anyway.
But no, I mean, I had one person say to me that the TSH is not relevant to monitor. You should just keep your T4 within the normal range when you dose thyroxine.
And that person may well be right. The problem is that in medicine, it's just not done that way. So if you do it differently, and the patient then, for example, you discharge the patient and the patient goes somewhere else, then that person will look at it and say, oh, this doesn't make any sense because this is not the way I was trained to do it. Yeah. And, in medicine, people, I don't know what it is, that they don't tend to think for themselves all the time. So you need to look at it. You need to look at the patient, need to look and see how the patient is doing and so on. Doctors don't necessarily always can get over that kind of barrier. And so they tend to fall back into what they have been taught in medical school. And so I don't do it that way anymore. So because of the fact that otherwise, patients have no place to go beyond you, because they're not going to be able to find somebody who can look at it in that particular way. So I do look at the TSH, but bring the TSH down to a level where most doctors would feel comfortable, let's say between 0.3 and 0.5 somewhere. I think that I also believe in optimal values. For example, the same with the hemoglobin. Anemia, I believe in an optimal value, for example, for women to be about 13.5. That is in American standard. So those
numbers are in here.
Yeah, so I think also I look at these things a little differently than, for example, in that reference range where the 13.5 falls into. For example, if you have 11, which is still within the reference range, I would still consider that to be low, and would treat that. And the same with iron reserve. I look at ferritin. There's not an awful lot you need to look at. It's really limited.
I just look at ferritin and hemoglobin.
And ferritin and hemoglobin, I think, is just what you need to look at. And then you need to also look at it from what are optimal values. For example, for a woman, an optimal hemoglobin, I think, is 13.5. Ferritin, I'd like to be between 60 and 80.
Yeah, for hair, I like to be over 70.
70, no, that's that's perfectly fine as well. But, the reference range very often goes from 10 to 160.
Oh, yeah, for ferritin, it's like massive. So it's like, oh, your ferritin 16, that's fine. I'm like, no, it's not fine. So. And then the hemoglobin's 12.5. I'm like, no, that's going to make me feel unhappy. So I would rather have it be higher. But then I just kind of, there's a limit to how much I can mess around with stuff. Like, I don't tend to change people's thyroid medication.
No, and you shouldn't.
Because it's not outside of my scope.
Yeah, you shouldn't do anything you don't feel comfortable with.
No, so I feel comfortable doing it. I just know that the endocrinologist will lose their shit with me if I start to mess around with someone's thyroid. I'm like, why is a dermatologist doing this? Okay, so then, now you do a lot with facial pain. We're almost over.
Face pain.
Face pain. Yeah. And so, we weren't going to talk about this because well, face pain is headache.
No, it's not.
But it's not. So define the difference between facial pain and headache.
Yes. So in terms of the location, if it's below the level of the eyebrows, the focus of the pain, if it's below the level of the eyebrows, we call that face pain or facial pain. It is a different issue from headache. Diagnosis and treatment are totally different from headache. A lot of headache, quote unquote, headache specialists also consider them to be face pain specialists. However, they don't have training in that sense, and I don't think necessarily do patients do them a service by trying to treat their face pain. The issue with face pain is that face pain is also very common. Probably affects easily 7-8% of the population. Migraine affects about 15% of the population, so it's twice as common, but face pain is still quite common. And the most important issue, I would say, is that doctors generally only know one face pain presentation.
Trigeminal neuralgia.
And that's trigeminal neuralgia. Trigeminal neuralgia is extremely rare, and gets overdiagnosed. And also, as a result of that, gets overtreated. And very often that treatment consists of brain surgery. So they end up with a hole in the back of their head. I'd like to emphasize that the most common cause of face pain is, in fact, what we call temporomandibular disorder. It's a muscular condition affecting the jaw muscles. And you can have either pain on both sides or on one side. I think that is really the most common cause of face pain, but also more common than trigeminal neuralgia is face pain related to the nose sinus issues. And the problem is that temporomandibular disorder is something that comes with dentists.
Yeah.
While not all dentists by far know anything about temporomandibular disorder. So where do these patients go? Physicians in general tend to know nothing about it. I was a professor at Tufts University School of Dentistry for over a decade and was a member of the Craniofacial Pain Center at Tufts Dental School and learned a lot about temporomandibular disorder. I write about it in my book as well in terms of diagnosis and treatment. So physicians tend to know nothing about it. The dentists very often also don't, although it's traditionally considered to be part of their practice. And then when you talk about nose and sinuses, ENT physicians tend to know very little, if anything, about face pain as well. So again, it's a huge vacuum. And so that's why I included it in my book, because I consider myself to be a specialist both in headache as well as face pain with the training and work experience that I have.
Yeah. Okay. So So you need to find the right doctor for that as well.
Yeah. So although the book is called Headaches, if you have face pain,
you can read the book too.
You can certainly get a lot of benefit from reading the book as well. It's in chapter 16. It's the last chapter.
But I do think a lot of people with facial pain think they have headaches. It's connected.
Headache, certainly, I think it's more common for headache to go into the face than it is for face pain to go into the head. Although face pain can certainly also be a trigger of headaches. For example, if you have a bad temporomandibular disorder with jaw pain, you can certainly trigger your migraine headaches. And I have treated chronic migraine patients who have daily headaches with frequently occurring migraine headaches just by treating their temporomandibular disorder.
Okay, good. All right.
Absolutely.
And just to finish off the this podcast, so you do write at the end of the book that you were diagnosed with kidney cancer, renal cell carcinoma in 2015, and that made you realize that there's more to life than work. So at the age of 62.
62. It's exactly 10 years ago.
10 years ago.
Yeah.
So there's more to life than work, including horse riding and guitar playing. So that's what you spend your time doing now.
So that's what I started doing again. I used to ride horses when I was a young boy for a short period of time, and as a teenager, of course, this was when the Beatles were going strong. Every boy wanted to play the guitar, including myself, and I hadn't gone back horseback riding or playing guitar for about, I think, 50 years or so. So when I was realized with the fact that
more to life.
I had developed cancer. I thought I need to do something for myself. And so these were the two old hobbies that I picked.
And then you're like, let me write another book. So there's more to life than work.
Yeah, but that was really
from me.
your doing.
That was my work, my fault. That was my fault.
But I really felt that that I wanted to share my knowledge and experience, with the broader audience, because I really didn't have the sense that, the dozen books that I had written for the medical professionals had made any impact at all. I don't know that any physician ever read any of those books that I published. So
if you're a physician,
I have no illusions about any of that.
Hence, I'm not going to write a book for other different topics.
And maybe that's the best way to do it. Maybe I just wasted my time doing all of that. I've also written a lot of publications, but I really wanted to, headache and face pain, so many people suffer from it. So many people suffer from it. And I just wanted to make sure that, I share my knowledge and experience to the best of my abilities. And that's what I've tried to do in the book. So it's really, my view on headache and face pain and the way I have come to approach that based on my training, especially with Dr. Brigham, and my decades of experience working in practice. In practice that was always dedicated to headache and face pain. So I've never practiced neurology.
Never any kind of normal neurology.
No.
So regular neurology. So I think that's a nice way to end this. So basically, if you have headaches or facial pain, and you want to find a solution to that problem, because there are certainly solutions, then you can't get more than 50 plus years of clinical experience in a book, and explain in a very understandable way with no references, which is also helpful, because references can be confusing. It can be really annoying to read a book with references.
Yes.
So have a look at this book, and like the audiobook is also available. So if you don't want to read, then just get the audiobook. But yeah, thanks so much. I think that was super helpful. Any questions, let me know. And like I said, you can get the book on Amazon. You can also follow Professor Spierings at Dr. Egilius Spierings Instagram, where he basically talks a lot about the stuff in the book.
Exactly.
All right, good.
Okay.
Thank you so much.
Thank you.
Thank you.